And when I was asked to do a presentation, I think what was really important for me and how I bring myself to this role is to acknowledge the lived experience as the neighbourhood lead and what I have to offer as a neighbourhood lead. And I think it was very important to put lived experience front and centre, really. And that's why it's in the title, because lived experience and that building services with people from our communities is absolutely crucial as part of our values as a neighbourhood team. So I think that's really important. Just from when I think about the pandemic, for me, and I'm sure this will be similar to lots of other people, is it's absolutely been a story of challenges and opportunities. And I guess I can't emphasise that enough, really. And I think the beauty of the neighbourhood team and the role is how we frame those challenges into opportunities. And I think what's important is what we've learned from the pandemic is that it's actually been able to accelerate some of the blockages and barriers to place-based care for us in our neighbourhood. The other thing for me as the neighbourhood lead is it was noticing what I kind of reference as the contagion. I think we'll all remember the toilet roll gate and the pasta gate and the supplies that were needed, and people's rush to buy out shopping when we first went into the pandemic. And I guess what for us in our neighbourhood, we were very cognizant of that contagion and how rapidly it spread, that response, really, and that filling that space of worry and concern within our neighbourhood. So I'm also going to reference something else, and I guess for me as a neighbourhood lead, one of the things that I live with is dyspraxia. And so when we went into the pandemic, I'm still working on it. That's another presentation, but I have still yet to get all my full access requirements in place. But again, that is a challenge because everyone else had started to work at home. So all the other leads and other staff members had started to work at home and using that technology in that way. But actually for me, it was really important that because I was able to stay on site with the community nursing team, that it really, something that was a challenge, it became an asset throughout the initial phases of lockdown, and I'll go into that a little bit later. You'll all, I'm guessing that you'll all have your work family, and I guess for me, what the challenge of not having my full access to work requirements that became an opportunity was that I was able to bunker down with the community nursing team and provide the support and challenge the myths of what was going on in the wider neighbourhood and through that Gold Command process. And I think it would be fair to say that it brought me together with that team in that work family approach. And I think that is probably one of the biggest learning things, that something that could be so challenging as not being virtually connected and equipped to do the job actually became one of the greatest opportunities for me to connect with the nursing team, dispel myths, provide information and be there on a daily basis at huddle and handover. Because that's not generally the work that I would have been doing, but in this situation, in that urgent response, I was able to do that. And for me, they provided me with that grassroots intelligence of what was going on clinically, what they were concerned about, the PPE worries, the worries about workload, the worries about donning and doffing and working differently. And just actually leaving the family at home in lockdown was something that they shared and we worked together on. So that was certainly an opportunity. The other thing that was a learning for me was how much we were valued by the community and our neighbourhood. So that's from businesses, community and voluntary sector, from other workers around the system. And I think, you'll see there that actually this letter came from one of the neighbourhood nurses' children, and how they were so grateful for what we're doing. And I guess what is really that really important, the learning for me, is that being valued and us showing value to others. And I think that there was nothing more beneficial than that to carry us through in those initial times. I guess what will be the learning going forward into our second phase will be how do we kind of keep a momentum and our staff resilience around this next phase. So being valued, looking after ourselves, and acknowledging the fact that key workers are beyond the NHS. And I think that's the thing around neighbourhood. It was very clear from the very beginning that key working is not about just the NHS. It's about community and voluntary sector. It's about bus drivers. It's about carers. It's about home care. And I think we as a neighbourhood in place-based care are well positioned to be able to champion that neighbourhood lens on everything we do. And I think that's really important and a valuable learning from what I took from that first phase of lockdown. So just to go into the structural, and I'm absolutely sure that everybody else went into Gold Command and linear communications, as you would do with any urgent situation. And it's absolutely brilliant for dissemination of information and escalation. And I've even heard since that people are suggesting that that'd be great as a continuing format. However, if I draw upon that contagion, which we mentioned earlier, it does nothing to connect the neighbourhood. And I think that the thing that's really important is it's valuing that for what it is, but there was absolutely a gap. For me, I hit a big birthday while we were in lockdown. And yes, I have had over 30 years in health and social care, but I absolutely felt a novice in this situation. And actually, that was the greatest asset, because so I could come in and absolutely leave my expertise at the door and come in and learn together and be part of the solutions and the opportunities together. And I think the thing that we noticed very rapidly around the contagion is that we wanted to fill the space. We wanted to fill the space with good stuff. You will all be familiar with the messages on Facebook, Twitter, the high street discussions, the family discussions, which were at times borderline conspiracy theory and not helpful. So I think the focus that we did is that how do we put into place something to fill that gap, to fill the space in place. And so we rapidly put in what we call a Bringing Services Team Together neighbourhood huddle. And I know that others will do that meeting, but it really accelerated that connectivity across the neighbourhood. So we filled the space in place with good news and good stuff. And it was also a place that we could get that rapid grassroots intelligence. And actually what we know from working as a systems leader is that the system throws up challenges and issues. So very rapidly, it became very clear there were issues around people with food and food poverty. It was very clear and very quickly identified in neighbourhood that medications were going to be an issue to get to people who were living in isolation and vulnerability. And I can't emphasise this enough, that we now have a place and it was coordinated by the council, and it's absolutely fantastic on a citywide basis that pathway and that provision's in place, but it came from neighbourhood. The rapid action of community and voluntary sector and our workers at front line started to put that into place individually in neighbourhood. And then we, as any rapid design process should work, we rapidly escalated it to locality, to citywide, for then to be taken on and standardised. And I think for me as a neighbourhood lead, this is really important, because at times there can be a rub at locality and citywide from a neighbourhood lens. I'm not sure what other experiences are, but from mine it is. And the rub is when there is a push down from a citywide or national strategy without actually seeing what's going on at grassroots. And I think what we can do, and what we did do, is we took up and threw up what the issues were at grassroots, rapid design methodology, and to take it forward and then to standardise. And I think, I guess what I'm saying as a neighbourhood lead is, I think it's about getting comfortable with that rub. And so I will say that I could say how many meals they've provided. I could tell you what pathways are being put into place, that our care navigators, our health development coordinator were part of that process delivery. I guess the learning for me from it would, and I've said this at locality and citywide, is that if you are going to do a pathway around that, you need the people who are doing it, and that's where the real rich intelligence comes from. So I guess learning for me would have been to have a health development coordinator on those pathways, on those project teams, and I think that's the thing that will come out of this in the future. But it's the confidence to walk towards the rub, and as a neighbourhood lead, I think it's really important that. The other thing that became really clear was that we needed to contact people, vulnerable people, and there was a group of people that were not contactable, and what was really clear is that the housing were having some challenges around this. So very quickly in neighbourhood, we were able to put into place a triage process for that approach. And by the end of it, we'd gone from a list of over 100 people down to 7 people. And it was literally going through a series of checking whether they've been in contact with other services. And we were fortunate to have a redeployed person from case management to come into neighbourhood with mental health experience. And it really brought the emphasis of the value of mental health, because to be honest, they looked at the list and there was a significant number that they were aware of already from involvement with the service. There was some footfall done, some door knocking. It was again grassroots intelligence, where they would see a neighbour sat outside and the neighbour would say, "Oh no, they're a relative." And through that process, we then handed it onto our neighbourhood policing, and they were part of this approach. And we were able to really minimise the list that was non-contactable. So that was a real opportunity we took from this pandemic, and also around the data cleanse. Really, I guess the other thing that became the system threw up to us, and was around the digital, the inequalities and the digital inclusion. So we had meal vouchers unable to be accessed because they couldn't be printed off. We knew that there were going to be, and there had been a rise in domestic violence. So things working with community and voluntary sector, putting posters in shop windows with the number on, printing off vouchers with Bernardo's, and our health development coordinator put together what we called rainbow bags, which was hard copy information, and doing it by footfall. And we have a frontline workers forum that supported that. So it was taking these real challenges and getting out there to those that really hard to engage or fail to engage group of people, and that became a great opportunity that we took in the pandemic. I think the other thing as well, which it was not really this was a significant challenge. So we wanted to look at doing a standardised safe and well check across the system, and it sounds quite an easy task, but if I give some reference point, this check had been part of a working group that hadn't been developed for over a year because they couldn't get to an agreement. What the pandemic for us did is it gave us the opportunity to go with a test and fail and a design methodology with accepting imperfection and good enough. So what we know is that we have coordinated this safe and well check through a housing set of questions. We've coordinated it with social care liquid logic, primary care EMIS and community care EMIS, and a hard copy for community and voluntary sector. It's imperfect, and we know that it will need to be iterated, but we have something that we didn't have before, and it goes across many different systems across the neighbourhood, and that is a real triumph. And we market it and we've sold it in an imperfect design, and we will put a review date, and we will work and improve it as we go along, and that's been really a success of the pandemic. And I think the other thing for us is reaching out and filling the space. Our health development coordinator led on a comms approach, which was around sound bites and interviews on the radio station. So using multi-methods to engage different audiences within our neighbourhood, and sound bites and interviews around mental well-being and social prescribing, information for older people, COVID information, and working from a health and social care basis across the council workers together in a shared methodology. And that actually became another way to establish the value of a neighbourhood lens, flipping the model of what into place-based care. I'll also just touch on what we see as an innovation, which is an acute home visiting pathway that was developed. And it was developed within primary care context with neighbourhood support, so it was developed across both. And I think the learning that came from that was this was for people who had symptoms of COVID symptoms and were at home, couldn't get into practice. Either that was a physical couldn't get in, or transport. So not only did we recognise the need for these interventions, it was also recognising the inequalities and the inequity of our city, and what could we do to problem solve that. So we put in this acute home visiting pathway. There was a cross-systems project team. And what we were fortunate enough, because we'd been working around patient experience, lived experience, we had a lived experience affiliate with us. And very quickly, there was, I guess, the question and the challenge, rightly so, was in a rapid approach, in an urgent scenario, do you attend to equality analysis? Do you attend to having lived experience as part of a project group? And the lived experience affiliate said, well, it might just be the difference of whether you walk into it or you phone up a person and you refer to them as a she or a he. And it absolutely engaged the primary care staff. And from then on, they realised, I think, in a working context, the value of recording protected characteristics and working with those within the GP standards, and brought them over. So that was an innovation, and it helped to move along the inclusion agenda within primary care and also within neighbourhood. What was really important for us as well is that we did value being in this together across neighbourhood. But the thing I think as a neighbourhood team is that we notice things, and we notice things early. So I think whilst I am a neighbourhood lead, I also do the regional chief nursing officer BME advisory group role. So I work with the regional chief nurse on, working with our BMA nurses as a big population of the workforce to look at those areas of development. And because I have that lens and I'm connected in a neighbourhood context, but also an organisational regional context, we thought it very important to notice, and we were noticing things, and we were noticing the disproportionate impact on our colleagues. And so throughout this, we put into place extra meetings, and we focused on communications to our workers, because at the end of the day, as many of you will know, people who work within health and social care are the people that live in our neighbourhoods. And so we put in lots of communications. We did blogs, comms, focusing on risk assessments, and you will see on that photo that we as the nurses group, we attended a staff member's funeral from one of our organisation, and connecting together was really important. We noticed that our colleagues were dying, and we were living through this at the time, and it was really, really emotional, and notably so. However, what I can say is that as this group, and also the Bringing Services Together group, because at the same time we'd had the death of a housing colleague, is that we were able to, through our huddles and through our connectivity, acknowledge this was happening, but also give each other support and that we needed, sharing information, sharing resources. And I guess the question for me would be, not just from that nursing role, but actually from our neighbours, this story of the pandemic, or was it a story of Black Lives Matter and PPE? Because that was very much in the forefront, what was happening from the team's point of view, and also from our neighbourhood's point of view. And that has progressed now. And I guess for us in our organisation, on the back of that, it's been fantastic to acknowledge that we, that we were doing things at a national level. So I can give you, we've got reports where we've had events where we've had 200 to 300 nurses at each event. And we've got plans of action with the Chief Nurse of England to address some of the challenges and the disproportionate impact on BME. And we also have had lots of involvement at Manchester level and Greater Manchester level. So we've now got a Chief Nursing Officer group for BME, and looking at how we can influence this work on all levels, really. And I think pretty much making the statement that we are working towards becoming an anti-racist organisation. And I think really pandemic and my lived experience, it would be remiss of me not to actually put that as another thing that was front and centre, but the learning. And again, I will say that the pandemic, it's been a challenge, but actually it's also given us the opportunity to leverage, not only for staff, but for our own neighbourhoods, the importance of inequalities and equity in what we're doing, and starting to flip our approach, not only to neighbourhood lens, but that population health approach. However, that said, I did manage to get a little bit of me and family time, and I think it's really important to acknowledge that. And yes, I do love Cornwall, and it will always be family, sea, sun, but it's always jam first for me, definitely. So do make time for your, for your self-care. I think that was one of the big learning. I'm going to rapidly move on to another project that we did throughout the pandemic, and so again, I could give you the numbers. But again, for me, the neighbourhood learning is not just about the numbers, it's the stories, it's the experience. And the numbers that around this is that we were approached to do a project right in the middle of all this going on. We had a group of people seeking asylum coming to our neighbourhood, and within the first week, it went from 7 people to over 250 people. Who had to be put through a process of primary care, registration, etc. And for me, this was cutting-edge innovation. It was a flipped model of primary care delivered at site, on a hotel at site. As you can see there from that photo, they were adapting spa rooms into a kind of a consultation room. We had the challenge of putting in place all the PPE and the signage. You will see also we had to be creative in how we were sharing public health messages and social distancing. So we brought in digital technology. And I think the bit that I want to emphasise around this is we took this, and before we built the business case for it, we got the project team together and we asked lived experience into the room to tell us that as their story, and they told us their story from their perspective, and we populated the equality analysis, and we used that to then build the business case. So it's that famous line where we were flying the plane and building it at the same time, and I'm so proud that we had that in place. We ended up we've put in a whole host of support with the Health Development Coordinator. So Health Development Coordinator had negotiated an offer from community and voluntary sector where we'd got interpreters on site. I mean, we've got, this was at the same time where politically it's a challenging situation, and then also there'd been an incident in Scotland which wasn't, which was not, was going to cause, media attention. But if you can see there, we've got a programme of wellbeing activities, gardening. It was responsive, and our health development coordinator put that offer in place, and that was part of our equality analysis. So I guess what's in neighbourhood space for us, we need to, tackle the notice the contagion, put the right stuff into neighbourhood space, the good stuff, bringing services together, that team around the neighbourhood, shared priorities became food and nutrition inequalities. We're now moving on with our shared plans for winter resilience. And I guess it's that data-led, and data for me is the lived experience, the professional data, and the actual data. And I think what's important is that we frame it in that quadruple aim, which is people's experience, outcomes, team experience, and of course, everything is, we have to be mindful of funding. So we've moved on, we've started exploring the future. But I guess for me, a big message is what we're able to do is what's in neighbourhood space, ask that question often and notice the contagion and fill it with good stuff. So for me, the neighbourhood lens, responding to the pandemic and my lived experience as Neighbourhood Lead was a story of absolute opportunities and challenges, and I was privileged to be part of that journey. Thank you. Do you have any questions?
That was really good. Excellent. Yeah, very inspiring.
So yeah, I'm not quite sure how long we've got left, but I'd welcome any questions. I'm not quite sure what people might have expected from the presentation, but I think I could come and give you numbers. But I think what's really important in neighbourhood, we are about working differently and trying to make sense of that data that is not always in numbers and KPI sense. I'd really welcome comments, but also questions on some of the challenges and opportunities. Yes, Gemma.
Julie, I'm just going back to where you were talking about the people that were not contactable and the police. When we first started out, we had quite good links with our PSR hubs. And I know Stephen's got a PSR hub in his area, and they were very much part of our meetings, but because of governance, they weren't allowed to come to the meeting. So I just noted that you got support then from the police to get that number of 100 people down to 7. How did you do that? If that makes sense.
Yeah, so actually the police were brought on as the final, really, in a triage process, to be fair. And what's interesting is that if you think about that from a mental health context, if mental health deem it, they would do that anyway, wouldn't they? So what the learning for me was we'd had a couple of people come to case management, mental health workers to case management. They'd all just started and then pandemic hit. So that team at Manchester Case Management was redeployed, and what we were able to do was we were able to bring them in and support with pieces of work because they were redeployed. But what the asset was, which we'd not had in Neighbourhood, is the mental health asset. And it was literally Nathan, who was brought to our team, looked down and said, oh yeah, I know several of them. And he had that knowledge anyway. And so we were able to triage before we got to the police. And of course, if there's somebody we would have concerns with, they would talk to police about that anyway. That's how their process would work from a mental health context. I think the other thing around the mental health is that we were able to then use Nathan's expertise on the people seeking asylum, because every person came with trauma and our trauma-informed approach. So the opportunities in pandemic they were just throwing these opportunities up to us. We did have to have that collaboration though, and a trust to be able to do things differently. So the trust came from practice, partnership, neighbourhood team, and just trying it out. I mean, you know, the practice who took this on, you know, before the business case was put in place, they went at risk financially because they have a fund, so they had to employ people and go at risk and sub this as an approach. But I think it's because we have a strong neighbourhood team. I mean, we in Manchester, I think you might be aware that we have neighbourhood and PCN model, which me and Paul, with the clinical lead, clinical lead, we're very clear to our neighbourhood lead role. I was very clear when I first went in that boundaries were not part of how I would practice. Of course, I am held to account sometimes about that, but generally people will know. So I guess, you know, when we first started, we had no line management or budget. We now line manage the nursing lead, but I have the same meetings, whether it's with a nurse lead or a mental health lead or a social care lead or all of us. I give them the same information. I do it. I might call one a one-to-one, and I might call the other one-to-one catch-up, but it's the same. And I think it's working like that. So I've deviated a little bit, Gemma, but I hope that gives you a little bit. And I think the police bit is I think people who work in health, social care and community voluntary sector adapt at navigating around obstacles. Mm. So, and that's what we did. So some pieces of work since, so on building on top of that, we've addressed the DPIA, the governance aspect of it. So that's the stuff around sharing information from practice to team, so general practice to team. So we did do that in a formalised way, and that we addressed that. But yeah, I think it's something. I guess the question is do you, and I'm saying this as do we feel that we have that permission to do it, and that again, that age-old thing where it's, you know, don't ask for the permission, do it and then ask for it afterwards.
Ask for forgiveness later.
Yeah. So, but I think I've just realised that's recording. But yeah, it's that kind of thing really. It's a little bit of rock the boat a little bit and work around it. And I think in a systems leadership, it's seeing the pathways through. Is there anything else? No. Is there?
Sorry, Julie, I was just going to follow up on what Gemma was saying. I guess in the early days we had our fingers burnt, I'm going to say, again, I'm aware that we're recording, with the police in our area, where information that was shared within our active case management was then used as intelligence, and some of our housing providers also did use some of our, so I guess that's why in terms of governance we had to put in a stronger barrier, I guess I'm going to call it, because it then became a barrier to true neighbourhood working, really.
Absolutely. So there is, I think I also work, Paul is the lead, he's the digital lead for the commissioning. So I am lucky because my neighbourhood GP lead is also the digital lead. And so I'm constantly reminded of those edges. but it doesn't stop us from kind of trying to address it in a practical way and appropriate way, either changing that through a DPIA. And of course, remember in pandemic, we were in a different situation, so some of it was necessity, around invoking that necessity as well. So I can imagine that, and that's the beauty of neighbourhood. It's bespoke, isn't it, to what's your experiences in that neighbourhood.
And I guess what we did in my neighbourhood was we found another way into the police, so we might have excluded them from some discussions, knowing what was going to happen to the information, but we had like Gemma was saying, we had a good link with a PSR hub lead, and Berry have stepped those down while they review what's going to happen with them. So we lost our connection with the police and our connection with housing and some of the wider sort of public health services,
Yeah, and the other thing is, I think the good enough and imperfect philosophy served me well, because we struggled after when the initial lockdown for bringing services together to convert an urgent meeting that was weekly. We were sharing intelligence, offering to share PPE. We had housing, home care, primary care, everyone there, to then convert it into an operationally type, longer term. We've got goals for the future, because people were in recovery state, and actually that became quite a busy time. So now we've reverted back again, and I think you just have to. It's constantly adapting what's right with maintaining principles, really. And I think if we're looking for perfect all the time, especially in this current landscape, we won't do anything. So, sometimes we have to accept that it's imperfect and it's iterative, and keep championing that, really. Yeah. Anything else?
I suppose these roles as well, that it's like you said before, Julie, they're so new that you're forging almost like not through treacle. It's been, I suppose, for working through the pandemic for you all, it's been treacle, but you've also unblocked blockers which may not have been unblocked without this pandemic happening, because I think things have escalated. Absolutely. And I know from my colleagues in Bury what they've been doing over the last 6 months, as things have been put in place that maybe would not have happened if the COVID hadn't hit. But also I think for us all it's been quite nice to listen to, because you often wonder, are we doing it right? Are we all making a difference? But there's no sort of blueprint for it. So some of it is trial and error, and it is, I like what you just said about the good enough and imperfect philosophy, because actually that sort of does probably mirror how we all think about it.
I think that's thank you for that, Gemma. And so the bit that so I'm a nurse by background, and the beauty of Manchester is it's a group of many professionals. So there's social care, previous practice manager, police, etc. So we came into the roles with that. We brought our professional identity into the role as well, and because we've got that mix, it's really helpful for interest. So we work on a neighbourhood level, and then we have leads for citywide stuff. So for me, I brought the workforce race equality standard work with me, the work around BME and inclusion with me, and I'm interested in forging links in practices, so nursing in practices. So that bit is additional, but it's part of the neighbourhood lead role. And I think what we are very good at is flipping from taking grassroots intelligence at neighbourhood level to then looking citywide, regional, national, and we have to be adept at that and constantly. So you can't stick with perfect. You have to, flow with it, and we have to respond fast. And if we were playing word bingo, we'd say agile, but that's exactly what we have to do. And I think I could give you the mathematical equation for imperfection. It's it's satisficing, that, you know, it has a mathematical equation. And I think for us as neighbourhood leads is to be confident in there is evidence and concepts and you know, plenty of reason of why we should use this approach. And I was chatting to someone the other day about you know, the difference between a medical model and a social model, and how if I was explaining sepsis to you and looking at cellular level, it wouldn't be questioned. You know, that is absolute. But then, you know, we've got other methods and knowledge and intelligence that we can share as well as that neighbourhood lead, and this is the rationale I'm doing it. So I think there is a role in sharing with our teams. These are the reasons why we're challenging power, because we know this gets the result. Co-production is well established. This gets the result. The evidence shows us this. So whilst this presentation has been framed in a lived experience and a discussion, all the things that I've talked about are well grounded in theory, concepts and evidence. It just might be also a different kind of evidence, perhaps a qualitative or design approach or whatever. So I don't know if that's helpful, but yeah, I quite like it. So. Anything else? I think we're heading a little bit, I'm not quite sure. Fiona, do you want to say anything? Or oh, has she gone? Is that it now? So shall we call it a day? Yeah. Right, I'm not quite sure the etiquette, but it's been absolutely lovely. I've started following a couple of people on Twitter, and for those neighbourhood leads in the room, there's so much to share. Please, let's get a meeting together. I'm really looking forward to it, and I feel like the more of us out there, we can start to share a bit of knowledge and become a voice to contend with. Yeah, definitely. So enjoy your weekend, folks.
Thank you.
Bye. Bye, everyone. Bye.
Bye.